Roxana, that was a very nice introduction. Thank you very, very much. It's really an honor to be here. And I am going to talk to our percutaneous mitral valve therapy. It is probably the next frontier, or it probably is the frontier now. So these are my disclosures. As you can see, I get financial grant support from every company, so I'm so conflicted and I'm a very neutral person. So the mitral valve disease, there's two real disease processes. That's mitral stenosis and mitral regurgitation. I'm going to be very brief on mitral stenosis, but I should mention something about it. The mitral stenosis is an episode of carditis, leads to healing. The hallmark of rheumatic carditis is basically commissural fusion of the mitral valve, leading to stenosis, and then fusion of the subvalvular apparatus. As William Boyd described it, it's a disease which kisses the joints but bites the heart. And this is a disease process which leads to severe stenosis or sometimes regurgitation or a combination of both. Rheumatic mitral valve disease still is prevalent in certain parts of the world, and we still see a lot of these patients in the United States. The significant mitral stenosis can be treated in most cases with transcatheter mitral valvuloplasty, but it should be mentioned that if you go to Asia or in India, you will notice that the patients are younger because they have more episodes of carditis. On the other hand, you see more older patients in the United States. Transcatheter treatment in most cases is equivalent or superior to surgical commissurotomy replacement, and this statement is relevant to younger patients. The best technology still is the Inouye balloon. The best way to prove the point is that this fact is that the balloon hasn't changed for 25 years. And the fact that it hasn't changed means it really does work. Don't you agree with that, Igor? It is a safer procedure, and Igor is one of the pioneers of this procedure. And he actually did a lot of work on the double balloon technique, but then this was superseded primarily on the basis of safety and the fact that you can do progressive dilatation with a single balloon. How do we go to the next slide? So if you just compare balloon versus open surgical commissurotomy, it clearly shows that baseline 1 week and going up till 10 years, there's almost an equivalence of balloon mitral commissurotomy versus surgical mitral commissurotomy. In fact, probably even better. So just to put it in perspective, PTMC is recommended for symptomatic severe mitral stenosis, the criteria for severity being now 1.5 centimeters, not just 1 centimeters, with a favorable anatomy in absence of moderate to severe MR. And surgery should only be indicated for severely symptomatic patients who are not, when I say severely symptomatic, class 3, class 4, who are not candidates for PTMC or have failed PTMC. And PTMC is also reasonable in patients who are asymptomatic with severe mitral stenosis, less than 1.5 with a favorable anatomy. So it is still a common valvular disease. Clinical features of left heart echo is still effective in making the diagnosis, and balloon valvuloplasty is a very effective procedure. And since Igor can tell you it has not changed for the last 25 years, and if it hasn't changed, it means it does work. Now we're going to switch to mitral regurgitation. I never thought in my lifetime I would see this happen, that we could actually percutaneously treat mitral regurgitation and repair. Mitral regurgitation is a little bit more complex. It's like women, they're very more complex. And you can see over here, you can be either a primary disorder of the mitral valve, and here's an example of that where it's, say, a functional MR. The first one, of course, is, how do I go back to the slide? Yes, when you talk about primary disorder of the mitral valve, it means there's a pathology of the leaflets or the cords. And obviously, it's very simple. If you have a primary disorder of the mitral valve, the treatment of choice is repair or replacement. On the other hand, when you're dealing with functional mitral regurgitation, which is actually a more common problem, it's primarily a ventricular disease which leads to apical displacement of part of the papillary muscles leading to MR. The problem with this, we don't know really what, how, and when we should treat these patients. But to make it simple, that if you divide them in two groups, if you have a primary disorder of the mitral valve, it's the valve that makes the ventricle sick, and the treatment of choice is a mechanical solution. On the other hand, when you see a functional MR, it's the ventricle making the valve sick, and so the controversy is there's a primary treatment should be still medical treatment for the LV dysfunction, including CRT, and then if the MR persists, then treatment of MR. There are several percutaneous approaches of mitral MR, and the one that seems to have led to the most number of patients is the leaflet repair with the MitraClip procedure, with using the MitraClip procedure, and that for the timing has now become standard of care. The rest are emerging options. If you look at now standard of care, let's understand the concept of the MitraClip. Everybody knows that the MitraClip is based on the Alfieri stitch, even though it's slightly dissimilar from what he originally described. But what it is basically coapting the malcoaptic segments together, creating a double orifice competent valve from a patient who has an incompetent single orifice valve. Obviously, the fundamental for this to work is that you have to have a localized area of malcoaptation that could be either functional or degenerative. So you can have functional. But the beauty is that this technology is therefore adaptable to both degenerative as well as functional MR. The technical aspects, it is a transseptal procedure, and therefore it's very well guided, and you can notice there are no guide wires. You don't add any guide wires into the LV, and you can direct the catheter from the transseptal position into the left ventricle, and then you can direct the entire procedure by echo, grasping the leaflets. It is sometimes challenging. I find this part the most challenging is grasping the leaflets, and you can see it's usually a slow grasp. You allow the leaflets to drop on the ventricular arms, you close the clip, and then if you like it, you deploy it, but if you don't like it, you can still release it. So the beauty of this procedure, it's repositionable and removable, and therefore it actually is very safe. The procedure should be described as very complex but safe, and you can see over here you create a double orifice valve. Now the beauty of this procedure is, of course, its safety, but the bad part is it's actually sometimes a long procedure. And as Samir Kapadia mentioned, that of the complications associated with the procedure, the only complication that I've really had in the procedure is that when it goes too long, your pants fall off. So that's the only major complication that I've had. But really, you don't have a perforation cart in a vascular cart, because you don't have a perforation, you don't have a vascular complication, because it's a venous procedure. So if you look then as these are the concepts, it really creates a coaptation of leaflets, it creates a tissue bridge, and then I think the most important is the third one. That is, it restrains the LV wall. So it's a bridge between the leaflets, the clip, and the cords, which maintains the geometry of the ventricle, which I think is essential, especially for functional MR. So the attributes, as I mentioned, it's applicable to degenerative and functional, but the most important thing is it's repositionable and removable. It's a venous procedure, therefore the vascular complications are extremely low, and the risk of stroke is very low. Case selection, of course, is very critical, because this procedure cannot be done in all cases. It must be understandable, and therefore the primary modality to decide whether you can do a procedure is based on echo and TE to understand the morphology of the valve. But these are the traditional criteria for the MitraClip procedure, where you have a central MR, where the flail gap is not too large, or the coaptation or the malcoaptic segments are not too separated. However, we've actually extended the indications after, and we can see we now can easily do A1, P1 flails, A3, P3 flails. We can now do patients with failed surgical repair with the reganglionoplasty or artificial cords. We've actually done a few cases with hypertrophic cardiomyopathy, where you stabilize the anterior leaflet and prevent its SAM, and it can be used as in end-stage heart failure with MR who are almost in cardiogenic shock. So these are the extensions of this procedure. And here's an example of a gentleman that we recently did, a 71-year-old gentleman who had mitral valve surgery with artificial cords. 10 days later, he presents with severe shortness of breath and a loud systolic murmur. And you can look at the echo, you can see that one of the cords has snapped. And so we brought this patient back and then actually did an Alfieri MitraClip procedure. The MR disappeared. Both the patient and the surgeon felt very comfortable and was discharged next home. So this is a way you can actually show a failed surgical procedure being helped by a MitraClip procedure. Let's look at the long-term data. There's a lot of long-term data with this procedure. It's over 14,000 patients, actually now almost 15,000, and over 2,000 patients in various forms of clinical trials. The majority of patients, especially in the commercial setting, has been high-risk patients. And October 24th of last year, the FDA finally approved the MitraClip for a limited risk for patients with high-risk MR, for primary MR, which means primary disorder of the mitral valve apparatus. The real wordings are primary disorder of the mitral valve apparatus in bracket degenerative. If you understand the data, I'm going to show you some randomized trials. Everybody knows this randomized trial, which was very, very well criticized and brought to the ground because it's a bad study. But I'm going to show you some very interesting data from this. It was a 2-to-1 randomization to clip versus surgery in standard risk patients. And what we had shown in our first one-year data, that it was safe, it was safer than surgery. It had less reduction of MR, but equivalent clinical benefits at 1 year. The concern at that time was the fact that 20% of patients required surgery in the first 6 months in the MitraClip procedure. We now show you the 5-year data. And if you see the 5-year data, if you look at intention to treat analysis, the 5-year data shows equivalent mortality at 5 years. In fact, you can see over here the freedom from mortality is very high. Freedom is extremely good in both the surgical group and the MitraClip group. If you now look at freedom from mitral valve surgery, notice on the left that 20% of people required surgery in the first 6 months. But between 6 months to 5 years, very few patients required surgery. So what was the explanation of that? The explanation was most of these patients were in the first 6 months were people with abnormal leaflet pathology. We were actually naive when we started, and these were people we never got a good result to start with, and these patients became symptomatic and required surgery. But it must be understood for the patient that was its first operation. But then now you can see once those patients are removed from the curve, you can see that between 6 months to 5 years, very few patients require surgery. So if you correctly select the patients and you get a good reduction of MR in the beginning, there is evidence of durability. The MR reduction, you can see, persists up to 5 years, 80% of people remaining 2+ or less. Another important point, a lot of people have said, oh, you're left with 2+ MR at 30 days and 90 days. This is all going to become 3+, 4+ at the end of 5 years. But that's not true. You can see over here, they persist with 80% remaining 2+ or 1+ or less. If you look at functional class improvement, watch the curves on both sides. Surgery on the right side, left is MitraClip. You can see both groups did extremely well as far as functional class, both at 1 year, persisting up till 5 years. And then finally, another controversial point about the absence of a ring during this procedure is telling that progressive dilatation of the ring will take place. This is a proof of principle that if you do a MitraClip procedure, there is stability of the ring because of the bridge. So we summarize that the 5-year data is the longest prospective follow-up of 2 therapies for MR. The clinical benefits provided by MitraClip as well as surgery are durable through 5 years, and beyond 6 months the rate of mitral valve surgery is low in both the MitraClip arm. So we now go to the Everest-2 high-risk data. This was the data which was used for the submission for the FDA panel. And you can see here that no patients, there were a total number of patients with 351 patients. The mean predicted surgical mortality was 11%. Functional MR was 70% of the groups, and previous open heart surgery in 60%. The death rate at 30 days was 4.8%. Stroke was only 2.6%. Myocardial infarction 1.1%. And if you look at the Kaplan-Meier of survival, 95% survival at 30 days, 77% survival at 1 year, even in this very sick group of patients. The MR grade, if you look at the pair data demonstrating between baseline and 1 year, showing that 80% of people had 2+ or less MR at 12 months. This translated into a functional class improvement of 80% NYHA 2 or less. This also translated into reductions in hospitalization, which I think is important, especially with functional MR patients, where 50% of patients had a reduction of hospitalizations. So we summarize in high-risk patients, it's safe, it is effective, it makes them feel better, and it keeps them out of the hospital. So the FDA panel, as you know, voted for safety 8-0, supporting as far as effectiveness. It was a tied vote with the chairman, who was from New York, voted against us 5-4. And the overall risk-benefit ratio favored approval for high-risk patient went in favor of 5-3. This finally led to an approval after a long debate for prohibited risk patients in October 24, 2013. And the AHA-ACC guideline was updated in 2014 to demonstrate that it is meant for, look at the words, chronic severe primary MR, stage D. It's a 2B criteria with evidence of level B. But what I also want to show you that there is no level of evidence A for any criteria for surgery. So most of the level of evidence for surgery is B. So what about functional MR, which I think is a larger population? Well, we do know that medical treatment is the mainstay, and the role of surgery is quite controversial because it's often high-risk patients. They've demonstrated symptomatic improvement. There's a high recurrence rate, and there's no mortality benefit, and there's no sense to prepare whether repair or replacement is better. In fact, the surgery that people do is rings, and there are actually more rings than surgeons because every surgeon has a ring in his name, which just tells you that why it doesn't actually work. If you look at the data for functional MR on MitraClip, this is the largest cohort of patients treated in the world. It's been shown both with the non-randomized data from Europe as well as the high risk. This is the commonest treatment option. It's very safe. There's evidence of MR reduction. There's definite evidence of clinical improvement and LV remodeling, but there's no randomized data comparing medical therapy versus MitraClip as far as rehospitalization is concerned or survival. And that has led to two studies called the COAPT and the ReShape study. And the COAPT study is in North America, which is trying to randomize patients to best medical therapy versus best medical therapy and MitraClip. And I doubt whether this is going to be enrolled in the next 1 year. Most of the technologies are in the early stages of development with other technologies, and some have failed, and there are no clinical trials in the US with the other technologies. There is one of these technologies which I like to talk about, which is quite interesting to me, is the direct annuloplasty with a surgical-like ring done percutaneously through a transseptal approach, very similar to a MitraClip procedure. It takes some time, but you can actually get a C-shaped annuloplasty ring. You can actually tighten it with the reduction of MR. There are almost 24 patients done in the world, and it's actually demonstrated to be very safe. This is just an example of the first-in-man case with this Valtech device. With this, I'm just going to go a few words on transcatheter valve replacement. Where do we stand with that? Well, maybe this is a solution for a larger group of patients. You don't have to do anatomy. It'll be suitable for a larger group of patients. Stenotic, regurgitation, calcification, it doesn't matter. So these are the total number of companies which are involved. These are actually some of the list. There may be even more. I hope it doesn't become like renal denervation. But you can see over here, there are actually a lot of companies, and the ones with the blue lines, the ones where there are actually patients performed. So let's start about the challenges of mitral valve replacement, and it is not a tabby. Why? Well, it's going to be delivered to a very large sheath, and these large French sheaths are almost 30 French or more, and therefore they require sometimes alternate approaches like transapical. The fixation is going to be critical because this is an elastic ring, so the fixation cannot be just on the level of the annulus. There are concerns that patients will not be able to tolerate perivalvular leaks. There are issues about hemodynamics with the ventricle, MR gradients, and then obstruction of the LVOT. And then finally, of course, durability. And we do know that a mitral valve prosthesis lasts shorter than an aortic valve prosthesis. So having put that together, these are some of the access routes which have been challenging. First is a transseptal approach, which I think is very early in development. The transapical may be the first route, and then maybe directly through the atrial approach. So see, these are some of the approaches that have been tried. So let's talk about one of the first, Edwards valve. This is the Edwards first-in-man mitral valve replacement. There's been multiple. This is a very large profile sheath, 40 French in size through the apex. 5 cases have been performed, 4 in London, 1 in Toronto. Successful in all the 5 patients. Follow-up up to 76 days, maybe now 90. 3 deaths between day 4 and day 76, 2 patients surviving. The Tiara mitral valve prosthesis is a very interesting technology that I can see over here. It's actually a D-shaped valve which accommodates and prevents LVOT obstruction. This is also a transapical approach. 2 patients have been performed successfully in Vancouver. 1 died at day 60. The second patient is doing well. Then he comes to the cardiac to transcatheter valve replacement technology. These were the first technologies ever to be used in a patient, and they've got some major characteristics. But the most important is the fact that this is a different type of anchoring, as well as the fact that this can be done transeptally as well as transapically. The first patient was done in 2012. The patient died 4 days later. There was a hiatus for 2 years, and they did the second patient only 2 weeks, I think about 3 weeks ago. And this is a patient who had a very complex Barlow's valve in 88-year-old patient, which was treated by a cardiac Q. And you can see over here the patient did well, was discharged about 7 days after hospitalization, is doing very well. So this is our own experience. In Cedars, we've done now 200, actually since yesterday, 213 patients with a primary success of 95%. What I want you to show is the in-hospital mortality of 0%. This is actually a very safe procedure. We don't have a loss. Partial clip detachment of 1%. There's never been a clip embolization. Stroke rate of 1.5%. No cases of urgent open heart surgery. So we conclude by saying that there are several non-surgical approaches for the treatment of mitral valve disease. Balloon valvuloplasty is an established treatment for mitral stenosis. There are novel approaches which have been developed for mitral regurgitation, and the MitraClip is the leader of the field, but several other technologies are developing and showing promise. And treatment of MR, unlike aortic stenosis, will be a toolbox where there will be a role for both repair as well as replacement. And this is the most important slide to understand the mitral valve. The mitral valve is not a simple trileaflet valve. It has a greater function than that. You can see that the anterior leaflet acts like a rudder and allows the flow from the left atrium to go along the posterolateral wall, and then when it closes, it allows the flow to go through the LVOT. So that's the reason why nature created such a complex apparatus. And therefore I would say, what is the best mitral valve apparatus? It's the patient's own mitral valve apparatus. So always try to preserve it. Thank you very much.
Saibal, what an incredible topic, and given what you know and how we're seeing that the enrollment in the COAPT trial, which is quite slow, where do you think we're going to be with treatment of these patients? With who is the best candidate for a mitral clip in your mind now?
So, you've brought up a very sensitive point about functional MR and when it's going to be with the trial. Maybe your grandchildren will be still growing up and we'll be still enrolling COAPT study. But the point is that whether one should have this study. So I'll give you two case examples of, we are the still lead enroller. We had a patient who's a 72-year-old. He's a physician. He had functional MR. He was in class 3 heart failure. He fulfilled the criteria. He has 30% EF, severe MR. He came to Cedars and he obviously didn't want to have this thing. He wanted the clip, but I said, you can't have it. You've got to have this randomized study. So I put him in the randomized trial. He went home. He came back almost in hypotension. His cardiac index was 0.9. He was then immediately put on an inotropic drip and then put with a lot of this thing as status 1A for transplant. This patient cannot be randomized. So obviously he was taken on randomized list. So as a compassion, I decided to do 2 MitraClips in this patient. So I took him on a weekend, put 2 clips in the procedure. He went home in 3 days. He's completely normal 2 months later. So my ethical question is, do we really randomize these patients? And this is a patient I tried to put in the COAPT study.
Well,
I would have loved to have randomized this patient and shown.
Well, you better start randomizing patients in the COAPT study. Well,
I'm the lead enroller. I think it's time for you to do that.
I think it's difficult. No, I know it's really difficult, and I think your point is so well taken. We have the exact same kind of an experience.
I would love to have this patient in the study and show that he randomized to medical therapy, because he would have gone and had a transplant the next morning.
No, there's no question. So thank you so much for this.